Hello, my name is Ikuo Hirano, Professor of Medicine in the Division of Gastroenterology and Hepatology at Northwestern University, Feinberg School of Medicine in Chicago, Illinois, USA. It's both an honor and pleasure for me to be here today discussing my favorite topic, eosinophilic esophagitis. My disclosures are listed here. I will be discussing off-label use of medications. Currently, there are no medications yet approved by the US FDA for the treatment of EOE. As all of you know, the prevalence of eosinophilic esophagitis has been rising quite dramatically around the globe. This recent study from a pediatric group in Brazil noted a population prevalence of eosinophilic esophagitis to be quite similar to what we're seeing in other reports from the Western world. So for the next 15 minutes, I'd like to review with you what's new and what to do for EOE. First, we'll look at the treatment goals for EOE. Secondly, we'll look at what's new with the old therapeutic regimens for eosinophilic esophagitis. And third, we'll look at what are novel treatments that are under development. So what is the goal of treatment for eosinophilic esophagitis? We take a treat to target approach. The first target is symptoms. We want to see resolution of symptoms of dysphagia in our adolescent and adult patients without the need for our patients to avoid hard texture foods like bread or meat. Our second goal is to resolve the histopathology, trying to get that eosinophil count to under somewhere between 5 to 15 eosinophils per high power field, keeping in mind that the normal esophageal eosinophil count is 0. The third goal or target of treatment is endoscopic improvement. We want to see interval resolution of the inflammatory features that include the edema, exudates, and furrows, but also improvement in the remodeling and fibrostenotic complications of disease. Namely, we want to see an improvement in the esophageal diameter to 16 or greater millimeters in our adult patients. Looking more closely at this treat to target approach, again, we have symptom activity, which can be minimal to maximal. We have histopathology that can go from an eosinophil count of 0 up to hundreds of eosinophils per high power field. And we have endoscopy, which can be normal, or we can see a high degree of both inflammatory and fibrostenotic features. The optimal treatment for eosinophilic esophagitis would give us a bullseye target, getting a complete response in terms of symptoms, histopathology, and endoscopic activity. Complete non-response would be something in the outside of this circle where we fail to achieve our treat to target approach. Now let's take a look at different examples of the treat to target approach. This is the patient of mine who has obvious endoscopic activity. Biopsies show 100 eosinophils per high power field, and this patient has pronounced symptoms of dysphagia. The patient was treated with swallowed topical fluticasone, and on repeat endoscopy, his symptoms have resolved, histopathology has nearly completely resolved, and endoscopically, there's near complete resolution of the endoscopic inflammatory and fibrostenotic features. So this would be an example of an on-target bullseye response. In contrast, here's a similar patient with endoscopic activity, histologic activity with 94 eosinophils per high power field, and a high degree of symptoms. After treatment with fluticasone, this patient's histology improved, in fact, completely resolved, going down to 0 eosinophils per high power field, but the patient continued to have symptoms of dysphagia, and endoscopically, you're continuing to see rings of the esophagus and a high-grade esophageal stricture. So this would be an example of an off-target therapeutic response. We've achieved the histologic target, but not the symptom or endoscopic targets. A third example of an off-target therapeutic response will be what happens if you perform esophageal dilation without using medical or dietary therapy. If you perform monotherapy with dilation, you can make your patient's symptoms of dysphagia markedly better. In fact, over 90% of patients with EOE who have dysphagia can have resolution of their dysphagia with an adequate esophageal dilation. However, dilation does nothing to the underlying inflammatory process. So this would be an example, again, of an off-target therapeutic response. The patient feels better, the endoscopy strictures can look better, but the histopathology does not change when using only esophageal dilation. The second topic I'd like to address is what's new with the old therapeutic options for EOE. When we talk about the initial therapeutic options for EOE, we talk about the 3Ds. That includes drugs, namely proton pump inhibition and swallowed topical corticosteroids. The second D stands for dietary therapy, and the third D for esophageal dilation. Now, just a couple of comments about using PPI therapy for eosinophilic esophagitis. As all of you know, PPIs are no longer required for the diagnosis of EOE. Instead, we consider PPIs to be an effective therapeutic option for EOE. PPIs were recommended in the recent 2020 AGA Joint Task Force on Allergy Immunology guidelines with an overall effectiveness of 42% for achieving a histologic response to get the eosinophils to under 15 eosinophils per high power field. The effectiveness, widespread availability, ease of administration, and safety position PPIs as a very popular first-line therapeutic option. Keep in mind that most studies that have looked at the efficacy or effectiveness of PPI therapy have used a double dose once a day or a single dose twice daily. Loss of response to PPI therapy with prolonged use has been described in a few case reports, but appears to be relatively uncommon. The second category of medications commonly used for EOE are swallowed topical corticosteroids. Multiple placebo-controlled randomized trials have demonstrated the benefits of steroids for both children and adults with EOE. In fact, swallowed topical corticosteroids were the only therapeutic class given a strong recommendation in the 2020 AGA-JTF guideline, with an overall histologic response rate of 65%. A randomized trial has been conducted that compared fluticasone with budesonide and showed comparable efficacy for these two agents. In terms of side effects, oral and esophageal candidiasis has been reported anywhere from 4 to 16% of patients. However, symptoms related to the candidiasis are uncommon. Potential long-term systemic adverse effects such as adrenal insufficiency, growth suppression, or osteoporosis are being closely monitored in ongoing clinical trials. In terms of regulatory approval, the European Medicines Agency did approve a budesonide tablet formulation in January 2018, and in the US, we have the completion of a phase 3 trial of a budesonide liquid preparation or budesonide oral suspension, and we have an ongoing phase 3 trial of a fluticasone oral disintegrating tablet. Dietary therapies are also reviewed in the AGA-JTF guideline. There are 3 forms of diet therapy that include the elemental formula-based diet, the 6-food elimination diet, and an allergy testing directed diet. All 3 forms of diet therapy were given conditional recommendations, although the quality of evidence informing this was best for the elemental diet and the 6-food elimination diet. In terms of what foods you eliminate, if you follow the 6-food elimination diet, it means giving up milk, wheat, soy, egg, nuts, and seafood. There is a 4-food elimination diet that gets rid of the top 4 food triggers for EOE, including the milk, wheat, soy, and egg. A 2-food elimination diet that gets rid of only the milk and wheat, and a single food elimination diet getting rid of only milk, which has been the most common food trigger around the world. When comparing the different diet therapies, the most effective diet therapy has been the elemental diet. Following this, there are various forms of the empiric elimination diet. The more foods you get rid of, there's a tendency for a greater degree of effectiveness. And you see here that the allergy testing directed diets are one of the least effective diet strategies for EOE. To summarize some of the practical points regarding diet therapy for eosinophilic esophagitis, there is emerging data that supports the effectiveness of less restrictive diet approaches, including milk alone, a 4-food elimination diet, and a step-up approach. It's important to obtain a formal consultation with a dietitian, to involve an allergist when there's concerns for concomitant IgE-mediated food allergy, to outline to your patient the commitment for multiple endoscopies during the reintroduction process that can often require months. It's also important when you discuss diet therapy to review with your patient what foods are allowed during the elimination diet. For instance, if you're doing a full 6-food elimination diet, patients can eat all the meat and poultry they want. They can have rice, quinoa, all the fruits and vegetables in their diets. Finally, it's important to emphasize that the long-term goal of dietary therapy is not to leave your patient on a formula or a 6-food elimination diet indefinitely, but to identify 1 or 2 specific food triggers. When looking at the overall management of patients with eosinophilic esophagitis, again, we have the 2 broad categories of medical or dietary therapy. If your patients do not respond to medical therapy, they can cross over to diet therapy or vice versa. If your patient has persistent symptoms after induction therapy with medications or diet, and they have an esophageal stricture, dilation is highly effective at alleviating the dysphagia. And once you've achieved your therapeutic goals, again, you've treated the target, you've gotten rid of symptoms, histopathology, and endoscopic changes, you then go on to using maintenance therapy. The final topic I want to cover is what novel therapies are under development for eosinophilic esophagitis. Alternative therapeutic agents were looked at in the AGA-JTF guideline, including anti-IgE monoclonal antibody therapy. This was the only therapeutic class to get a treatment recommendation against its use, based on a randomized placebo-controlled trial that did not show efficacy for this type of medication. Other therapeutic agents that were looked at included anti-IL-5 therapy, anti-IL-13 therapy, and miscellaneous therapies such as montelukast, cromolyn sodium, immunomodulators, and anti-TNF therapy. All these additional therapies were given no recommendation based on what was deemed to be a knowledge gap at the time of this clinical review. However, since the publication of the AGA-JTF guideline, additional papers have been published supporting the efficacy of biologic therapies. This includes a therapy called cendakimab, which is the monoclonal antibody directed against IL-13. Cendakimab was studied in a randomized double-blind placebo-controlled trial of 99 adult patients who were randomized to 2 different doses of cendakimab versus placebo. The primary endpoint on the left-hand side was the change in the mean esophageal eosinophil count, which significantly was reduced by both low-dose and high-dose cendakimab. On the right-hand side, you're seeing the endoscopic activity significantly improve with cendakimab compared to placebo. Dupilumab is another monoclonal antibody with published data since the AGA-JTF guideline. Dupilumab is an IL-4 receptor monoclonal antibody that inhibits signaling of both IL-4 and IL-13. It has been approved in the US and in the European Union for the treatment of other extraesophageal allergic disorders, including atopic dermatitis, asthma, and chronic rhinosinusitis. Dupilumab was studied in a phase 2 clinical trial of adult patients with eosinophilic esophagitis and demonstrated symptom, histopathologic, and endoscopic efficacy. The success of dupilumab in the phase 2 clinical trial led to recent presentation of phase 3 clinical data at the allergy meeting just last month. Here, 159 adult patients were randomized to placebo or dupilumab given for 24 weeks. The co-primary endpoints, again, are histopathology and symptom improvement. And as you can see here, significantly more patients achieve both histologic improvement and symptom improvement compared to placebo. A number of other advanced therapeutics are being evaluated in phase 2 and phase 3 clinical trials, both for eosinophilic esophagitis and eosinophilic gastrointestinal disease. Before I conclude, I want to acknowledge that EOE really is an interdisciplinary disease that brings together gastroenterologists with allergists, immunologists, pathologists, nutrition specialists, and behavioral medicine specialists for the better care of our patients. So to conclude EOE, what's new and what to do? The therapeutic goals of EOE therapy include not only symptoms and histopathology, but also the remodeling consequences of disease. Swallowed topical corticosteroids optimized for esophageal delivery are highly effective in the management of EOE. Less restrictive empiric elimination diets are also effective for EOE. And the emerging data on biologic therapies for both EOE and eosinophilic gastrointestinal disease are quite promising. Thank you very much for your attention.